So just had a class on Wilms tumor radiation details, just summarizing that. So basically the management of Wilms tumor is summarized in this. COG group is the children's oncology group. This is basically American, what this is what the Americans follow, and Europeans follow SIOP. So SIOP is International Society of Pediatric Oncology. So the basic difference over here is COG goes with surgery first, then followed by adjuvant radiation and chemo based on the histology of. Here the histology is risk is basically favorable and unfavorable risk. According to SIOP, they first go with NACT, that is the chemo, and then followed by surgery, that is nephrectomy, and the HPE will tell us whether it is low risk, intermediate, and high risk. So that's the difference. Here it is based on favorable and unfavorable. Here it is low, intermediate, high risk, followed by adjuvant, CT, and RT. So that is what is summarized over here, and SIOP is called the umbrella protocol. So what are the advantages of COG? So by going with the COG, you will avoid giving chemotherapy to a benign disease. You will also avoid giving chemotherapy to a different histological type which may not need it, and this will also avoid any modification of tumor histology that can happen post NACT. And post NACT there can be loss of staging information also, so that can also be avoided in this. And like basically in the Wilms tumor, we avoid biopsy because of the risk of tumor spillage, and it can upstage the tumor. So that's why upstaging due to the biopsy can be avoided in COG protocol. In SIOP protocol, it's basically the advantage of the disadvantage of the COG. So here it is. Because we are giving an ACT, it will downsize the tumor, so it will decrease the size of the tumor, so the surgery will become simpler, and there will be decreased risk of tumor rupture. So when they are trying to operate, there are less chances that the tumor may rupture, and thereby reducing the chances of intra-abdominal recurrences. And this can also make the nephron sparing surgery, because NACT we are giving, nephron sparing surgery can also be possible. And this will also give us the information whether the patient is responsive to the chemotherapy or not. Now coming to whole abdomen RT. So basically in Wilms tumor, the two things, the RT is RT to the abdomen and RT to the lung. So whole abdomen and whole lung RT, whole abdomen or flank RT. So you did not give whole abdomen RT in cases where, as per the staging, we know stage 1, 2, 3, 4 and 5 is bilateral kidneys involvement. So 1 is confined to the kidney, 2 is with kidney with the local extension just near the capsule or something like that. So stage 3 will be where there is intraop spill, or biopsy has been done, or intraop spill is there, so the spill is there is tumor leakage to the whole abdomen. So probably you'll prefer flank irradiation where there is local extension, and you'll prefer whole abdomen RT where there is whole abdomen exposure like tumor spillage, so even in stage 4. So yeah, that was about the staging. So what will you do according to COG and according to SIOP? So according to COG, so this is FH is favorable histology. Unfavorable histology is divided into two based on focal aneplasia and diffuse aneplasia. So in focal histology, in stage 1 and stage 2 there is no indication of RT, but in stage 3 there is indication of RT that we give is 10.8 gray in 6 fractions, so 1.8 gray per fraction. So in unfavorable histology, irrespective of focal or diffuse aneplasia, there is indication of RT in stage 1, 2 and 1, 2 and 3 as well, but the difference is here a little bit. So diffuse aneplasia, unfavorable histology, in stage 3 we give 19.8. Now according to SIOP, low risk in stage 1, 2 or 3 there is no indication of RT, and intermediate risk, only stage 3 there will give 14.4 in 1.8 gray per fraction. High risk, there is no indication in stage 1, stage 2 we give 25.2. If it is diffuse neoplasia, and stage 3, if it's high risk, you give 25.2. And in both of them, if there is gross residual tumor anywhere in the kidney or anywhere else, spine or lung or anywhere, so there you give 10.8 gray boost. So now when will you start the RT in case of COG? You'll start the RT by the day 10, not later than 14. So basically 9 to 14 days will be your target within which you have to start the RT, beyond which they have seen high rates of recurrences. So this is what according to COG they follow. According to SIOP, the RT timings is within 2 to 4 weeks of surgery. Next. So this will be the conventional borders of the whole abdominal artery of flank artery. So volumes are whole abdomen for this technique, for this, and the borders over here is upper border will be the upper. So this is how you manually mark it. So upper border will be the upper border of the nipples, lower border will be the superior border of the pubic symphysis, and laterally the lateral border of the body itself. And we have AP. The fields that we use is APA and PA. This is AP and this is PA. So we have to shield the contralateral kidney. So kidney comes in the posterior region. So in the PA field, you will shield the contralateral kidney, and you'll also shield the acetabular and femoral heads over here. This is to prevent avascular necrosis. Now the RT field based on the imaging will be, so the upper thing will be the diaphragmatic dome, laterally will be the peritoneal reflection, and inferiorly the inferior border of the obturator foramen. Now coming to flank RT, the upper border will be the xiphisternum, lower border transtubercular plane, and medial border will be you have to include the whole vertebra over here as to reduce the chances of scoliosis later in life. So you have to include the whole vertebra in the medial border, and 1 centimeters to it. Laterally will be the lateral border of the body itself. Now the dose that we give is 10.8 gray and 1.8 gray dose per fraction. Coming to a whole lung RT. So whole lung RT, so if it's lung means it is already been spread to the lung, so it is stage 4 directly. So stage 4 according to COG group, for favorable, unfavorable and focal, and is irrespective of everything. So you have to give 12 gray in 7 fraction with the 1.5 gray in each fraction dose per fraction. So that will be according to the COG group. According to SIOP, in low risk there is no need for whole lung RT, but in intermediate risk you'll give 12 gray in 1.5. In the cases where there is lesser where there is no complete response, when they did 9-week post-op CT. In high risk they give 15 gray in 1.5 gray per fraction itself. Again, if there is gross residual tumor, you'll boost it to 10.8 gray in here also. So when do you treat the lung? So in according to COG, favorable, unfavorable, you have to evaluate at 6 weeks and RT at 7 weeks for the whole lung irradiation. In the RT timing according to SIOP, in high risk where there is complete response, you have to start RT within 2 to 4 weeks. If there is no complete response, you have to reevaluate at 9 weeks and post chemo and then consider. Now the borders for the whole lung irradiation. So the volumes is whole lung and the whole mediastinum and the pleural recess. So and the borders, superior border will be the middle 1/3 of the clavicles, and from here 3 centimeters above, that will be your superior border. Inferior border will be the xiphisternum. Lateral border will be the lateral border of the areola. And shielding, you have to shield the humeral heads and the larynx as well. Now again, the fields are AP and PA. The dose over here, I've written it wrong, so it is 12 gray, 1.5 gray per fraction. So so we had a case. She was a baby of 6-year-old female. It was a case of right Wilms tumor with lung mets, and there was also adnexal and D11 mets. So she had received 7 cycles of NACT, post right radical nephrectomy. HPU was a favorable subtype. We plan for whole abdomen irradiation, whole lung irradiation, and boost to the pelvis wherever there was disease. So the disease was in pelvis and ileum and spinal canal. So we plan to boost there. So the dose that was given was 10.8 gray in 6 fraction to the abdomen, 12.6 gray in 7 fraction for the whole lung, and boost of 10.8 gray in 6 fraction to the pelvis and ileum and spinal canal. So this was the whole lung volume. This is the lung bath that we treated the patient with, and this was the D11 boost that we had given. I did not get abdominal target volume. So the late effects of the treatment will be scoliosis. That's why we had, so previously they used to treat irregularly, and the median dose at that time was 30 gray. So at that time the risk of scoliosis was 54%. Now congestive heart failure at 20 years cumulative incidence is 4.4%, and end stage renal disease at 20-year cumulative incidence for Danish-Drash syndrome is 74%, for WAGR syndrome is 36%, with patients with GU abnormalities is 7%, and without any syndrome is 0.6%. Secondary malignancies at the 15-year cumulative incidence is 1.6%, small bowel obstruction at 15-year 15%, breast hyperplasia for female patients who are receiving whole lung irradiation, 4/5 of them had underdeveloped breasts, and the risk is pneumonitis. The studies which are important here is the chemo that is given with had NWTS is basically COG group itself. So NWTS had 5 studies. So first study showed that adding vincristine and actinomycin had better results. So stage 1 favorable histology, there is no need of RT, and they also said if RT is given, it has to be given within 9 to 14 days. And if there is only local extension, then only flank RT is enough instead of the whole abdomen RT. They saw that the no response to radiation was there beyond 10 to 14 beyond 10 gray. So 10 to 14 gray which was being given was not useful, so it's better to stick to 10 gray. So NWTS2 is where they showed the addition of doxorubicin for stage 2 to 4 favorable and unfavorable histology. So NWTS3 trials show that in stage 2 favorable histology, patient receiving VA, their RT is not needed. This had removed doxorubicin and given only VA in case of second stage favorable histology. And in patient with third stage favorable histology receiving 3 drug regimen, that is VAD, they saw that the 10 gray is equivalent to comparable to 20 gray, so it's better to give 10 gray itself. So according to NWTS 4, they showed that pulse intense chemo, 6 months of pulse intense chemo was equivalent or comparable to 15 months of conventional chemo. And NWTS 5 showed that LOH, loss of heterozygosity 1p16q, has a good prognostic importance. It shows us chances of increased relapse, and it also showed that in stage 2 to 4 with dysplastic diffuse aplasia, addition of cyclophosphamide and etoposide helped. And RN 05230533, the goal is to reduce toxicity in low risk, improve outcome in high risk with chemo intensification. That was it.